Good afternoon, everybody. First, we'll introduce everybody here at Silver Lake. Stephanie, we'll start with you.
Stephanie Harness, SEBC and Subcommittee Manager.
Good afternoon, Faith Rents, Director, Statewide Benefits Office.
Claire DeMatteis, DHR Secretary.
Leanne Hinkle, Deputy Director of the Statewide Benefits Office.
And Carol is on vacation today, much deserved. Stephanie, can you walk us through attendance?
Yes, absolutely. So we have Secretary Claire DeMatteis in person. Tuning in remotely, we have Controller General Miller. We have Chief Justice Colin Seitz. We have Sean O'Brien, Thomas Bracken, and Karen Field Rogers. Looks like we also have Secretary Manning joining as well. Are there any SEBC members that I missed? If so, please raise your hand and I can unmute your microphone.
Jordan, are you here to sit in for State Treasurer? Thank you for joining. Obviously, you know that you can't vote, but we appreciate you being here.
Thank you.
All right, we can go ahead and get started then. And as other members join, Stephanie, please let us know. We'll start with approval of the July 22, 2024 minutes. Has anybody had a chance to review them? Is there any additions or edits? If not, I will entertain a motion to approve.
So moved. O'Brien.
Sean, is there a second?
Ruth Ann, second.
Thank you, Ruth Ann. Any further discussion? All in favor, signify by saying aye.
Aye.
Any opposed? Any abstentions? Minutes are approved. Do we also have to approve the executive committee minutes?
Yes,
Stephanie?
Yeah.
Okay, separately, we met in executive session. We have executive committee minutes in your packet. I'll entertain a motion to approve those.
So moved. O'Brien.
Sean?
Second, Ruth Ann.
Ruth Ann? All in favor, signify by saying aye.
Aye.
Any opposed? Any abstentions? Chief Justice, we'll mark you as abstained. Thank you. Executive committee minutes are approved. We'll now move into public comment.
Great. So SEBC members did receive 3 written public comments. They were sent this morning as well as posted on our meeting materials section of the SEBC website. In addition to those written comments, we do have 1 public member registered for comment from the Delaware Healthcare Association, President and CEO Brian Frazee. You should be able to unmute your microphone, and we have 3 minutes for public comment.
Great. Can you all hear me?
Yes.
Yes.
Okay, thank you so much. Good afternoon. My name is Brian Frazee. I'm the president and CEO of the Delaware Healthcare Association. I wanted to speak today in response to some comments that were made during last month's meeting and with a request and offer to work collaboratively to address healthcare costs in a manner that will not take us backward on quality or access. During last month's meeting, this committee reviewed healthcare cost trends within the state health plan, and as has been the case, since the start of FY24, the consultants pointed out that cost trends have been driven by increasing costs on the pharmaceutical side, in large part due to increasing utilization of GLP-1 drugs. In fact, they are projecting a 148% year-over-year increase for those drugs, the weight loss drugs for FY25. However, hospital costs have not been discussed by the consultants at any recent meeting as a driver of the state health plan costs. In fact, the most recent meeting materials on key trends had cited that inpatient medical PMPY decreased 6.4%, driven by a decrease of 8% facility charges. And while pharmacy payments were driving 29% of the cost overall, and increased by almost 16% from the previous rolling year. It's worth noting that this is not unique to the state health plan. The most recent Delaware Healthcare Spending Benchmark report showed that the increases in inpatient and outpatient hospital costs increased only 3.5% and 4.1% respectively in 2021 and 22, whereas pharmaceutical costs net of rebates increased over 12%. But despite this, when discussing the healthcare trends and solutions to address these costs, we only heard a discussion on addressing the hospital side of the costs, through the Hospital Cost Review Board that was established by HB 350. And there was no debate on solutions that would target the primary drivers of healthcare costs for the state health plan. It is true, and we acknowledge that healthcare costs are in fact rising, and hospitals are working to do our part to address affordability that does not harm, in a way that does not harm healthcare quality or access. We're investing in primary care, behavioral health, and losing millions of dollars annually as these are not profitable service lines due to inadequate insurance reimbursement to help keep people healthier on the front end and prevent costly hospital visits later on. So all that is to say, we are committed to doing our part, but we can't do it alone. And we look forward to working collaboratively with this committee, with all healthcare stakeholders, the outgoing and incoming administrations, as well as the General Assembly on our shared goal of achieving a sustainable, equitable, and robust healthcare system here in our state. Thank you so much.
Thank you, Brian.
Thanks.
Except I see a hand raised. Somebody
Yes, and just noting for the minutes that Director Kate has also joined.
else. Hey, Director Kate.
All right, and I see a hand raised, phone number ending in 6099. Your microphone should be allowed to unmute at this point.
Good afternoon. Can you hear me?
Yes.
Yes. Okay. Good afternoon. This is Tom Pledgey. I have a written statement that's been given out to the committee members. Two questions. One is on page 3 of the 229 page document dump that we got on Friday afternoon. There's an item that reads that consultant services are going from a $4.1 million level to $4.5 million, 9.5% variance. Are these consultant services for WTW? And when will there be public comment and open review of what we're buying from WTW? Second, and most important, if you could look down on the page of the written document, you will see a form. It's titled FY25 Budget by Group Medicare Retirees. This form was given out at the joint SEBC subcommittee meeting last Monday. You'll note that on the form is some very interesting information. This is showing that in FY25, if you look at the left side of the form, the premiums that were generated were in excess of the expenses by $8.8 million. So 65 and over Medicare retirees, state retirees, did not cause the problem last year of the shortage. Now, if you look to the right side of the form, the projections for FY25 show what the premium contributions are with the 27% increase. You will note if you look to the far right-hand side that there is now a surplus that has grown from $8.8 million to $34.4 million. I don't understand why we are getting these surpluses. There was no reason to increase the post-65 premiums by 27%. If you will recall that this group is the oldest group of retirees, they're getting the lowest pensions based on retiring years ago at lower salary. Also, they're least likely to be able to get a second job. These are 70 and 80-year-old people. Most likely, they have very difficult health issues. On page 35 and 36 of that 229-page document you have today, take a look at what WTW is proposing for what they call long-term scenarios, that they want to increase the funds by 8 and 9%. Further, there is no reason to be increasing these premiums. Thank you for your time, and I appreciate your consideration.
Very much. Yeah, a couple more folks at least.
Yes, and wanting to mention that we also had the Lieutenant Governor has joined us as well.
Okay, so Lieutenant Governor, welcome. Director Kate, welcome. We're in public comment on the agenda.
I'm
Great, and it looks like our next public comment, we have Bob Clarkin. Mr. Clarkin, you should be able to unmute your microphone.
Hi, can you hear me?
Yes.
Great, thank you. Good afternoon. I sent in a written comment about the item number 8 on your agenda, which is Audit Services RFP. Way back in March of this year, I was researching something else, and I came across minutes of an SEBC meeting back in October 12th of 2020, when an RFP was released and then a contract approved with a company called Claim Technologies Incorporated, CTI, to perform biannual audits of the GIPS medical contract and the PBM prescription contracts. So I looked everywhere I could on the DHR website and other state websites, and I couldn't find copies of any of those audits. I looked over at the auditor's office and found many, many, many audits that the auditor's office conducts. Most of them, all of them made public and none of them redacted, but I couldn't find over there any of the CTI audits. So I put in a FOIA request back in May, and I'm still awaiting a result on whether or not those audits will be made public. Hopefully I'll hear back from the DHR by this Friday. But what really struck me as odd that CTI has been conducting these biannual audits since FY15. And I went back through all of the SEBC minutes, going all the way back to FY15, and I never found where those audits were ever presented to the SEBC, either in a full meeting or in executive session. When I worked for the Department of Labor, one of our mottos was, you get what you inspect. And I would think that if these audits are as good as advertised on the some of the handouts that are up on the SEBC site, this information would be very important to the members of the SEBC as they try to get a handle on controlling, identifying, knowing and controlling some of the cost that of the various Aetna, Highmark, and CVS are submitting to the state. Thank you.
Thank you, Mr. Parkin. Anybody else?
If you'd like to make a public comment, you can use the raise hand function or press *5 if you're on your phone. I think that should be it.
Okay, thank you very much. Faith, we'll move on to your director's report and subcommittee.
Thank you, Secretary. Again, this is Faith Rents, Director of Statewide Benefits. I just have a couple of updates to report out to the committee today. The first being with regards to current requests for proposals that we have in progress. The bid closings have occurred for those 3 RFPs. The first being the flexible spending account, pre-tax commuter, and COBRA request for proposal. There were 3 bids received for that RFP. The second being the employee assistance program, we have received 6 bid responses. And then lastly, for accident and critical illness, we have received 2 bid responses. So we will be engaging with your respective proposal review committees on those RFPs and beginning evaluation of those bid responses here in the next several weeks. With regards to 2024 open enrollment updates, there was information reviewed by Leanne Hinkle at the July meeting. I just want to call the committee members' attention to a couple of updates that were included in your meeting materials specific to the Highmark plan enrollment changes for the plan year that began July 1st. Compared to July of 2023, the Highmark Comprehensive PPO Family Plan actually saw a decrease of 3%, whereas there were slight increases in the other comprehensive PPO tiers, that being the employee and spouse, and employee and children coverage. With regards to the Highmark First State Basic Plans, we saw increases ranging from 0.1% for employee coverage to as high as 4.4% for employee and child coverage. The overall change in Highmark enrollment for both of those plans combined was actually a 0.3%, so 0.3% increase in subscribers for July of 2024 compared to June of 2024. So those were the only updates and revisions from that information reported by Leanne at the July meeting. I also wanted to draw attention to committee members that there was a statewide benefits office trainings and communication report included in your materials. This information will be provided to you quarterly moving forward and also posted on the SEBC webpage. So that information contained in Friday's materials was specific to the fourth quarter of fiscal year 2024. With regards to U.S. Digestive Health, I just want to update the committee. We are staying actively engaged with Highmark Delaware with regards to negotiations, which we have been informed are ongoing, and both parties being U.S. Digestive and Highmark, are actively engaged. Again, we continue to encourage state of Delaware non-Medicare Highmark members who have questions about services, including referrals to other network providers, as well as continuation of care, that they contact Highmark Member Services directly for assistance. The benefits office did learn last week that Highmark sent letters to state of Delaware Highmark members in July 23rd was the date on the letter, to officially inform those members of the provider termination effective July 1st. This mailing included letters to approximately 590 state of Delaware special Medicare members. Highmark has informed our office that those letters to the Medicare members were sent in error, and Highmark is in the process of mailing a correction letter that we expect will mail on the 29th, so this Thursday, to those same Medicare members to advise them that that letter was based on incorrect information and was sent by mistake. That letter will clarify that Highmark members are not impacted by the changes to Highmark's provider network, including U.S. Digestive Health, and reminding them that they can receive care from any provider in the U.S. as long as that provider accepts Medicare. So I just want to pause there. Are there any questions from committee members with regards to U.S. Digestive Health or those other updates that I just reported?
Any questions?
I Secretary, just have one other comment. I did plan to share with the committee members the FOIA request for the group health insurance plan audit reports that Mr. Clarkin mentioned during his public comment. We, in fact, DHR, that is, have been working with the Department of Justice along with Claims Technology Incorporated, who is the auditor for the medical and prescription plans, as well as the group health insurance plans, third-party administrators, and our pharmacy benefit managers, as required under the terms of our audit-related agreements and each of our administrative services agreements, on the redaction of information that may be considered by the vendors to be non-public under Delaware FOIA. This has been a very time-consuming review of the reports, but we are expecting to fully complete that within the next several weeks, at which time those reports will be provided, obviously, to Mr. Clarkin in response to his FOIA request, but they will also be provided to the committee and posted on the SEBC websites. Moving forward, DHR and the Department of Justice will ensure that future audit reports, when issued as final, will include versions for review with the SEBC and public session.
And I've certainly tracked this, weekly since we got the request. It is an extremely time-consuming process that involves very large of our state vendors, and they have to approve the redactions. We go back and forth and think too much is being redacted. It is not a simple process. I want to commend our Deputy Attorney General, Michelle Whalen, for all her help on this. And she stepped into this newly assigned to DHR and SBO. So it has been a significant process. There is by no means are we delaying this for anything other than the comprehensive review that it requires and the pretty significant back and forth with Highmark and Aetna and others. Any questions?
Thank you, Secretary.
Thank you. We'll move on to the financials and the July 2024 fund report. Brian, let's see you on our screen. Jacqueline?
Thank you.
There
Thank
you
you,
are.
Secretary. Thank you, Secretary. Can you all hear me?
Yeah, you're a little muffled, but yeah.
Yeah, sorry about that. I'm on PTO, so I don't have my normal setup. So I'm going to share my screen. Since I only have one screen today, if anybody has questions, just feel free to verbally interrupt because I won't be able to see hands.
Well, thank you for joining us on your vacation. I'm sorry.
Oh,
to interrupt
pleasure.
on
No,
this.
no worries at all. No worries at all. I should have scheduled better. So the first thing we're actually going to talk about is the trend assumption, since the trend assumption requires approval from the SEBC, and then ultimately the budget, the detailed budget discussion that we'll have following this is built assuming that the trend assumption here that we're going to discuss is approved. So it's a little bit of a building block. So we'll start with the trend discussion. Recall that previously when we discussed this last month with both the subcommittee and the SEBC, two key components of trend were discussed in relative detail, one being the medical trend assumption for active employees and pre-65 retirees. We had an initial recommendation at 6%. The SEBC requested that we raise that to the 8% that we've seen in the prior 4-year average. And then further discussion, you can see under both the MedicFill prescription drug trend recommendation for the EGWIP, as well as the non-Medicare recommendation, was done using a building block approach where we were recommending various assumptions by component, specifically GLP-1 drugs for weight loss, GLP-1 drugs for diabetes treatment, and then prudent RX savings with the non-GLP-1 trends staying at the same 9% trend assumption that we had historically been using. The subcommittee at the time requested that we wait and see what actual July came in at to see if the monthly trends that we were seeing had come down at all or continued, and then based on that, potentially update the recommended trend assumption going forward, specifically for the GLP-1 utilization. So we have more specific information relative to that in the slides that follow. Specific to the GLP-1 utilization and cost increases for weight loss management, the charts on the left show the monthly utilization, meaning numbers of unique scripts, and then the gross overall spend for each month dating back to the beginning of FY24, which is when the GHIP first started covering GLP-1s for weight loss. You can see fairly significant monthly trends. Those are trends month over month. So as an example, January was 48% higher than December, March 45% higher than February, with an average monthly trend of 18%. And then in the bottom chart, we show our recommended trend assumption for the year, with the one caveat that the July numbers, the 2,447 scripts and the $3.1 million in claim costs, are actual. So July was, again, 21% higher than June, almost exclusively driven by utilization. So we're not really seeing any significant changes in the unit cost or the cost of the specific drugs on average. It's almost exclusively driven by higher utilization. So based on the fact that we've seen such high double-digit monthly increases for the past 5 or 6 months, with February sort of as an outlier. We're now recommending that we continue to assume for the balance of the year higher trend assumptions starting to come down throughout the year. So 21 going down to 15, 10, 5, and then ultimately leveling off at a 2% per month increase month over month towards the back half of FY25, which would result in an overall average monthly increase of 4%, but yet still a 272% increase in total GLP-1 spend compared to FY24, with again FY24 still being somewhat immature. And then on the right, just a graphical depiction of what the monthly and annual spends would be using the historical data, and then this trend assumption on a go forward basis, with us assuming slightly lower trends leveling off in FY27, FY26, 27, and 28 on an annual basis. So this is a big component of the trend assumption. We have similar summary and results for GLP-1s for diabetes treatment. You can see at the top, actual FY24 spend had sort of oscillating high monthly increases and then negative increases, likely due to just certain scripts being filled for 90 days. So it's just a blipping. July, again, like the GLP-1 utilization for weight management, had a fairly significant increase in July at 12%. You can see that in the bottom. And since the GLP-1 coverage for diabetes has been in place prior to FY24, we're certainly seeing lower trends because coverage already existed. The recommendation is to assume a 1% on average monthly increase going forward, which would result in a 35% increase in spend year over year. So when you piece that all together, we look at things separately on the commercial side versus the EGWP side, predominantly because GLP-1s for weight loss are not covered under the EGWP. So we will see overall lower average aggregate trends on the EGWP side than we will on the commercial side. But if we, as an example, look at FY25, going back to what I stated earlier, we're assuming the same 9% trend on prescription drug spend before GLP-1 utilization and cost and before PrudentRx savings. That same large increase in GLP-1s for weight loss from 14 million to 52 million, 24 million to 33 million for diabetes, an 11% increase in expected savings from PrudentRx. That gets us to an overall aggregate net average trend of 29% on the commercial prescription drug side. And then similarly on the EGWP side, there really are only the two components, because again, there is no GLP-1s for weight loss here, nor is there PrudentRx on the EGWP side. So we would have an average aggregate trend on the EGWP of 11% for FY25. And then for purposes solely of just providing long-term projections, we assume that the GLP-1 utilization increases year over year will start to come down in FY26, 27, and 28, where we ultimately level ourselves back off at that overall average 9% prescription drug trend. Everything else in this presentation is just historical stuff that we presented in the past, background relative to overall environment around trend and macroeconomic factors. But these are the key components, and these are the assumptions that we're looking for approval from the SEBC to use for purposes of setting FY25 budget, and then ultimately for providing the long-term projections going out to FY28.
Brian, it's Claire. I want to be real clear on what we're asking for approval for. Active employees and pre-65, retiree claim trend, medical claim trend. We're asking for a vote to increase the trend from 6% for this fiscal year to 8% in FY25.
Correct.
Active employee and pre-65 retiree pharmaceutical claim trend, we're asking for an increase from the current 9% to 29% in FY25.
As an aggregate of
Medic-
those underlying assumptions, correct? Yep.
For Medicfill, the medical claim trend, we're asking for an increase from the current 3% to 5%. And for Medicfill pharmaceutical trend, we're asking for an increase from the current 9% to 11%.
That's
That's
correct.
what we're asking this committee to approve for the trend assumptions.
That's correct.
Are there further questions, observations about these suggested claim trends? And I'll say, as I think Faith mentioned, these have been approved by our subcommittees as well.
Sean, you have a question?
Sean, you're on mute.
Apologies. I have a couple of questions. Let me start with the pre-65, the active and pre-65 medical gross claims. So current assumption is 6%. Last month, Brian, you came to us and you gave us a recommendation of 6% as well to continue that. Now you're recommending 8%. Can you explain what the data that you saw was that justifies the increase from 6% to 8% in your recommendation?
Yeah, so the 8% was in the exhibit that you can, the slide you can see on the screen, right? The 8% was the average of the prior 4 years. Our original recommendation was to stay at 6, just in terms of ranges of trends, but based on what the GHIP has seen on average over the past 4 years. Actually, it was the SCBC that requested that we modify that assumption to 8% during
Well, I
last
don't know.
month's meeting.
Well, it wasn't the SEBC, just to be clear. They may have been members of the SEBC.
It was,
but we
you're
didn't vote
correct.
on that.
It was, that's right.
It was our discussion at last month's meeting, correct?
Right.
So
And I'll
And
say,
certainly
Sean,
there
Sean.
is any range of reasonability, right? It's not a, it's a little bit of art versus science, right? There's certainly a range of expectations relative to what trend might be. We're also looking out the rear window a little bit to predict what we think the future might look like. We do know it's a high trend environment. It continues to be a high trend environment. And it's an assumption used for purposes of setting budget. In terms of any future rate action, the primary driver will be actual experience as it emerges.
okay. So let's go to drugs. So because this is you're
Yeah.
recommending such a enormous increase in the trend, I need you to walk me through the
Mhm.
rationale for the assumptions
Right.
here, right?
Sure.
Which seems to be, I know you've hammered at the GLP-1 stuff. I know you come in here every month and hammer at the GLP-1 stuff, but let's walk us through why that's a reasonable assumption in terms of the increase in utilization.
Well, so again, let's go back to this slide and look at where the progression of the GLP-1 spend since inception of coverage, right? We started off with a low spend per month of $400,000 per month. By the end of the fiscal year, we were spending close to $2.5 million a month. July alone came in at $3.1 million per month. And you can see, again, with the exception of February being this outlier, January was up 48%, March was up another 45%. So in 2 months, the GLP-1 monthly spend doubled. Another 30% in April, another 23% in May, another 21% in July. There's a part of me that's fearful that this, what looks like such a very large increase, may not necessarily be a month enough, right? So we're going from the 21 that we've actually observed. So that's now part of FY25 experience. And still having it relatively come down in terms of month over month increased utilization, still fairly precipitously down to 15, 10, 5, 4, 3, 2, which ultimately will get us to about a monthly spend of $5 million, which based on the progression and the way it's been going month over month, certainly appears very reasonable. in terms of what we'll expect.
So, what do you know about the experience of any plans that have had covered GLP-1s for perhaps a longer period of time? What does that progression look like?
I don't know that we have many clients that have had GLP-1s in place, going back prior to 2023. And if they did, it was not to the extent that we have today with the newer drugs that are on the market and the way they're being marketed and pushed. And obviously the results that people are seeing, and it's relatively a snowballing type of a phenomenon. In the clients that I individually have not seen these levels, seen very large increases in GLP-1 utilization, not to this extent. Would certainly have to take that back and go back to the broader practice and then broader pharmacy practice in terms of what we've seen across the entire WTW book of business.
And Brian, when we talk about these numbers, put it in context of the rebates we're getting from CVS. I know because of proprietary information that CVS claims we can't talk specific millions of dollars that we receive back in rebates. But when you say that the costs have gone up 21, 12, 29%, whatever it is that before rebates, after rebates?
Yeah, so going back to the slide here with the individual building blocks to the 29%, for example, we do have forecasts in here of what we expect aggregate rebates to be, again, not by drug, by class or anything like that, just the GHIP overall, specific to the commercial side and the EGWP side. Some of it based on the market check that we've done, and then the rest just simply based on the anticipated increase in utilization of drugs. For FY24, as an example, we saw a much larger increase in rebates than we did on pharmacy spend before rebates. On the commercial side, we're not expecting that same dynamic in FY25. We're expecting rebates overall to go up less than that average 29%, due to certain things that are coming off rebate. And then expect the dynamic to flip a little bit going forward on the EGWP side. We are forecasting rebates higher than gross trend, but right now, generally a wash between the two, give or take a few points either side.
But to be clear, that's rebates across the board. That's just not specific to the GLP-1 drugs.
Correct. All rebates, all rebatable drugs, all classes. That's right.
So Brian, there's one thing I'm hoping you can help clear up for me, because we do have a slide that was given to us. It's on the website, SCBC website, so I think I can refer to it specifically. And it looks like it was prepared by CVS, but I don't know by whom it was prepared. It says demonstrating the overall value of GLP-1 management. And it looks at FY24, so July 23 through June 24. And it separates out GLP-1 spending for diabetes versus weight loss. And so for diabetes, it shows what it refers to as unmanaged net cost. And there's an asterisk, but there's no explanation of what the asterisk is supposed to stand for, right? And it says we spent $45.8 million what was the unmanaged net cost, right? And right, which is very different from the number that shows up in your slide number, I guess marked number 16, page 16, where it says we spent, or at least the gross cost was $24.7 million in FY 2024. Do you have any idea what the difference is there? And is that managed net cost?
So I think
what we're actually paying?
Yeah, so the unmanaged net cost, and maybe, I don't know if there's anybody from CVS, we may have to go back for just clarity on what I'm about to say is correct, but I believe the unmanaged net cost is prior to a lot of things. It's prior to contractual AWP discounts. It's prior to prior author utilization management programs. It's prior to rebates. So it's prior to a lot of things, maybe even represented as if you didn't have the CVS program in place and people went to the pharmacy on their own to get these drugs, you would pay $45.8 million as an example, right? The managed net cost, I am again assuming is both after prescription drug cost discounts, meaning, AWP minus, make it up 10%, just a made up number. Program savings in terms of avoided scripts because the program better managed the utilization, and maybe also after rebates. I'm not 100% sure.
Brian, it's Faith Rents, Director of SBO. You are correct, and our account executive with CVS just confirmed that via our chat. Mr. O'Brien, we can go into a little bit more discussion of this in executive session with the committee only, specific to a deeper dive into the data that we're showing right now. But we can't really have any more in-depth discussion about that in public session.
Okay, and I guess, so, I mean, just to sum up, my understanding then is that, that, I guess, we're showing in, I guess, slide 16 from WTW that our gross costs on GLP-1s for diabetes was 24.7 million, and this seems to be showing that our net cost was 8.9 million.
No, our FY24 cost for weight loss was 14.2 million.
No, I said diabetes. I think I said diabetes.
Oh, I'm sorry. My apologies.
Right, and then you could compare them. You're right. You could also compare
you're right.
7.9 million here to what you're
Right.
right, 14.2 million. Okay. All right. I'll let that go then. Well, for later. Thanks.
And the monthly, go back to sharing my screen. These monthly utilization counts and gross spend counts are strictly pulled from reports given to us by CVS.
Great. Thank you.
Sure. Secretary DeMatteis, if there are no other questions, is this a point in time where the SEBC would vote on the trend assumption, or would that be later in the
Yes.
meeting?
We're gonna vote on it now. Are there other questions, discussion points? If not, I would like to request a motion to approve the proposed trend assumptions for fiscal year 2025 as presented by Towers and recommended by the Financial and Health Policy and Planning Subcommittees of the SEBC.
Motion to approve. This is Josette.
Thank you, Secretary Manning. Is there a second? Secretary, Chief Justice Sites, is that a second? You're muted. Chief Justice Sites, can you try to unmute? I think it's on our end.
There we go. I needed my mic on. Thank you.
All right.
I second the motion.
All right, thank you. There's a motion on the table that's been made and seconded. Is there further discussion? Not all in favor, signify by saying aye.
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 Any opposed?
Aye.
Any opposed? No. Any abstentions? Okay, trend assumptions are approved. Thank you. Ryan, are there other items you want to cover in financials?
Please. So moving on to development of the FY25 budget. Again, these results or these budget numbers already assume the trend assumption just approved by the SEBC. And we can go through the budget development in detail. There's some nuances compared to historical budgeting. The first slide here, we're looking at enrollment.
Brian,
In
I'm
the
going to
gates
stop you. Brian, I'm going to stop you for 2 seconds for the
Sure.
SEBC's knowledge. we're gonna review this proposed budget now, and then it is slated to be voted on at the September meeting. Go ahead,
Okay.
Brian.
No, thank you. So here we have a picture of enrollment, again, by month and by plan. Historically, from a budget standpoint, we have generally assumed that overall average enrollment in one prospective fiscal year versus current and prior would grow by 1%. What we've actually seen over the past couple of years, that average enrollment has increased by more than that, closer to 2%. Generally a bigger bump in the beginning of the fiscal year, right after open enrollment results, so reflecting July enrollment. And then we see a slower, steady growth throughout the course of any fiscal year. You can also see that we've seen some shifting in enrollments over the last couple of years by plan. So the First Aid Basic and the CDH Gold plan have seen fairly significant enrollment increases over the past couple of years, 29% in the First Aid Basic and 16% in the CDH Gold, with the HMO actually seeing a decrease in enrollment over the last couple of years. So what we're assuming from a budget standpoint, you can see the July numbers for FY25 are actually in black. Those are actual open enrollment results for FY25. And then from a budgeting standpoint, we assume that those counts will increase monthly, assuming that same 1% per annum. So call it, 1/12 of 1% each month going forward from an overall enrollment standpoint.
Yeah, and I'll just note from a DHR perspective, we had record hiring years back to back, 2022, 2023. And obviously the more employees we hire, the more that are gonna sign up for healthcare. So that, and we see the trend continuing in hiring numbers for
Yeah.
2024.
So it's important that we budget for it, right? Because more enrollment means more premium, more claims. So that's why we've slightly modified the growth assumption on the enrollment counts. From a premium contribution standpoint, recall that the FY25 rate increase was 27% across all populations. The reason why at the bottom you can see certain cells are highlighted in brown with white font, that's because all of the groups are lagged a little bit differently in terms of when the rate action actually hits the fund. So for example, active employees on payroll, there are 2 premium deductions monthly through payroll, and it's lagged basically 1 pay cycle. So as an example, the premium contributions that the fund receives in July are actually the second premium contribution deductions from June, which didn't reflect the 27% because they were FY24 deductions, and 1 payroll cycle of FY25 deductions. So you can see that the increase happens over a couple of months and then levels out simply because of expected increases in enrollment. So the active employees are lagged basically a half a month. On the pensioner side, the state share is actually lagged a month. So the amounts received in July are all for June. And then the first time we see an FY25 amount hit would be in August. But the pensioner shares, the amount that the pensioners pay in terms of contributions, those are done on a current basis. So July and July, August and August, et cetera. And then on the Medicare side, the Medicare rate actions don't go into effect until 1/1/25. So it doesn't happen until all the way down here. But again, the state share lagged a month, so you won't see that until February, with the pensioner share hitting in January. And then similarly on the non-payroll side, the overwhelming majority of this group is made up of the University of Delaware. It makes up about 2/3 of the group. And the University of Delaware pays in arrears. So July is paid in August and it's September. So again, from a Medicare standpoint, we don't see that 27% increase until February. And then on the non-Medicare side, we generally don't see it until August. So that's just there to point out how the building out of the premium contribution revenue is done from a monthly standpoint over the course of the full fiscal year, reflecting again that 27% rate action that went into effect for FY25 and calendar 25 for the EGWIP. From an other revenues standpoint, a lot of different components, many of them specifically related to the EGWIP. So you can see we have EGWIP direct subsidy, federal reinsurance, year-end reconciliation, coverage gap discount. Those are all EGWIP related items. And you can see that they've changed fairly significantly within each component beginning in calendar 25. So you can see starting in January, primarily due to changes in government reimbursements coming out of the Inflation Reduction Act that has particularly significant changes on the Part D side, which is what the employer group waiver plan is. It's an employer sponsored Part D plan. And we have more specific details behind the individual components that we'll go into a little more detail to show you why and how. As an example, the direct subsidy is going from about $500,000 per month to more than $3.5 million a month, with similar decreases on the reinsurance side. And then the other revenue components are made up of rebates on the commercial side, affecting both active employees and early retirees, rebates on the EGWIP side, affecting just Medicare retirees. And when we talked about the trend assumption, this forecast of rebates assumes both changes in rebates due to the market check improvements, as well as changes in rebates due to expected future increased utilization in prescriptions. Participating group fees, simply for non-payroll groups, there's an admin fee for them to participate in the GHIP, and then other revenues made up of a bunch of variable different ad hoc components. Some were very small items, about 15 grand a month on average. Some related to low income premium subsidies and coverage subsidies on the EGWIP side, and then just other things that happen from time to time. And then you can recall just that one-time transfer of $7 million from OMB to keep the budget solvent, to keep the GHIP, the fund solvent from a cash standpoint at the end of FY24. Specifically to the EGWIP components, so here's a detailed buildup of the direct subsidy, which is the primary financing mechanism from the government, subsidizing the cost of Part D plans. You can see in calendar 24, that amount was about $17 per member per month, showing the actual amount. So this is dating back to January of this year. So we have actual amounts received from January all the way through July. You can see the January through June amounts were a little bit less than the 17, and then there was a true up, a catch up in July. So overall, an average expectation of $17 per member per month. That amount for calendar 2025 per data from CVS jumps all the way up to $118 per member per month. So that's the cause for the big increase from the roughly, again, $500,000 to a little bit more than $3.5 million per month on the direct subsidy side. On the flip side of that, under the federal reinsurance program, the amounts received, there's two components that go into this. One is a prospective payment, an amount that it's a subset of the $91 per member per month that's expected. You get that on a monthly basis going forward based on head count. The prospective payment, you can see down below in the footnotes, the 2024 prospective payment was roughly $71 of the $91, with the balance reconciled at year end and ultimately received 12 to 15 months after year end. Two things are happening in calendar 25. One, not only is the total PMPM decreasing from $91 to $62, but the prospective share is decreasing more. So the prospective share is roughly going from about 75% of the total down to about 50% of the total, or specifically $30.41 prospectively per member per month, with the ultimate balance showing up probably towards the beginning of 2027 as a year-end 2025 reconciliation payment. So those are the details behind the two. And then the coverage gap discount program, not significant changes happening here. The overall coverage gap discount amount is going down from about $89, should be PMPM, my apologies, to $85. So about 80 to about 96% of what it was previously. So those are the details behind what we see now in these big changes in the revenue components from the government funding of the EGWIP. But net, it's still ultimately good news. Net overall, the total revenues are expected to increase fairly significantly now in FY25 versus FY24. You can see in 24, all of these revenue components were about 230 million and 223 million if you discount and take out of the equation the OMB transfer of the $7 million, growing all the way to almost $273 million projected for FY25. So while some of the amounts are going down, the increases are more than offsetting the decreases for a fairly significant increase in other revenues expected for FY25. From a claim standpoint, so these all assume, again, the trend assumption that was just approved by the SEBC. You can see at the bottom here, year over year increases in total dollars, and you can see that they are higher than those trend assumptions. The difference is just the added increase in enrollment will obviously also increase claims. So this bottom row is the net effect of enrollment increases plus the trend assumption increases that we just reviewed and had approved. So as an example, you can see 31% overall expected gross dollars on the CVS commercial side, both pre-65 retirees and actives. Again, that's the 29% rough overall average aggregate number plus enrollment. Net across the board, we're expecting the actives and early retirees total paid claims to go up between 15 and 16% on average. The Medicare retirees lower than that at 10%, again, primarily because GLP-1s for weight loss are not covered for the Medicare population, or an overall average expected increase in paid claims for the GHIP of a little more than 14% year over year. From an expenses standpoint, the assumptions that are baked into the budget are that all expenses will go up by 3%, call it a CPI type of an adjustment, and any expense that is either per member or employee related will not only go up by an inflation assumption, but also by the increase in overall enrollment year over year. So you can see forecasted expenses to go from $48.5 million to about $50.8 million, call it roughly a 3 and change % increase. I know just for clarity, in one of the comments that Mr. Pledgy made a comment about consulting fees at $4.5 million. Not sure where that number was coming from. We've got roughly $1.8 million in expected consulting fees increase over FY24 at the same 3% assumption that we use across all other assumption sets. And I think there are some other smaller components besides WTW fees in here from an expense standpoint. But the overall budget from an expense standpoint across all expenses of the GHIP run at roughly that $4 million-ish amount per month. and a phasing of the budget by month, or maybe even more specifically, what the fund will look like on a monthly basis, assuming all of these assumptions and forecasts are realized. You can see that here in the middle, the fund will actually go negative in the early parts of the month as the FY25 rate action starts to kick in and throw off additional premium revenue to help build back up reserves from zero to a more reasonable, appropriate level. And then ultimately, again, based on the budget, the fund would end up FY25 in a cash surplus of about $66 million and about $34 million after reserves. And this assumes for now, just as a placeholder, not sure when it will happen, but for now assumes that the $7.3 million transfer from OMB will be paid back in August. And obviously it will be paid back when it is and will reflect actual results when that happens. And then slide 12 is just exactly the same as slide 11, just with more of the subset details of each of the revenue and claim components at the individual monthly level, with ultimately the same results expected at the end of FY25. Then from a long-term projection standpoint, recall that the rate actions are done in the aggregate, right? So the three groups that we've talked about historically, active employees, pre-65 retirees, and Medicare retirees, have been rated together as one fund. It has not been approved to rate them separately. We'll continue to look at that going forward. We wanted to focus in on trend and budget for this particular meeting, and then going forward, we'll go back to looking at the results of each of the groups independently, as well as producing separate potential long-term projections of each of the three cohorts separately. But from an aggregate standpoint, we have two scenarios here from a long-term projection standpoint. One being if we approve rate actions in any individual future year needed to fund the surplus and reserves needed in that individual year. And then we have an alternative slide, which I'll show next, which does the same thing, but assumes a smoothing of required rate actions going into the future. These results actually reflect the emerging July experience that we now know, which we'll go over in a minute. But if each future year was done independently, there would be no rate action needed for FY26, but subsequent 7% rate action and almost 11% rate action in FY27 and FY28, respectively. And if we alternatively smoothed that required rate action over that 3-year period to still ultimately end up with a $0 deficit after reserves at the end of FY28, that would mean roughly a 4% increase for all groups for FY26, 27, and 28. Again, all groups in the aggregate, not looking at the independent experience or producing and approving recommended rate actions for any of the coverage groups independently. And then the last slide, just for completeness in the budget, is a resummary of the trend assumption that was just approved. So let me pause there for any questions relative to the FY25 budget.
It's just a clarification. I appreciate slides 14 and 15. And they're important, and that will help inform this committee's decisions next March on the premium rate increase, if any, for FY26. But what you're suggesting on slide 15 is even if we don't need one for FY26 to avoid a larger increase in out years, the committee, the next iteration of this committee, starting in January, should look at some sort of 4.4%, some sort of smoothing recommendation, so that there are smaller increases each year over the next 3 years versus what we had to do for this current fiscal year, one giant big increase.
That's right.
But that's not something we'll be voting on in, like I said, next month. What we're voting on next month is just the FY25 budget.
Correct.
You won't vote on the premium rate increases until next March.
That's right. And we'll continue to update the long-term projections as monthly experience emerges throughout FY25 and any impacts that the actual results have over forecasted. These long-term projections will be updated, but that's correct.
Any further questions? And we'll move on to a further analysis of the Medicare open enrollment update. Faith, is it you?
I will be brief here. We wanted to just update the committee on what is happening with regards to Medicare open enrollment, our planning and preparation. So Stephanie, if you could move to the next slide, please. We have scheduled open enrollment for state of Delaware Medicare retirees for October 14th through 25th. This will be for their benefits effective January 1, 2025. So specific to when pensioners will receive more information, we here in the benefits office are working very closely with the Office of Pensions, and we are preparing to mail open enrollment packets and information on September 30th. The Highmark Special Medicare Medicare Plan booklet, we also plan to post on the statewide benefits office webpage in advance of open enrollment. However, we will not be posting this until publication of the 2025 Medicare and new plan document. So this is the Centers for Medicare and Medicaid's plan document for Medicare Parts A and B. That document is not available and typically released until late September. So we're in preparation for that. We're working on the Medicare plan booklet. But of course cannot finalize and publish that booklet until we can confirm that we're in complete alignment with the Medicare and new plan booklet. So again, we're targeting October 1st, but that is pending release of that Medicare and new plan document. Next slide. So new for this year, we have not done this previously for the Medicare open enrollment, but recognizing we've had interest from our Medicare retiree population for opportunity to come out, talk to Highmark, CVS, other vendors potentially supporting their Medicare benefits. We are going to conduct enrollment education sessions. We will be holding these in each county during open enrollment. For those Medicare retirees who are not local, we are also going to conduct virtual education sessions. So I can give you a little bit more details on that on the next slide.
And obviously, I just want to reiterate that this isn't new. You do this, we do this every.
We have not done education sessions for the Medicare population. This is new. We, prior to the public health emergency, were conducting education sessions for our active and non-Medicare open enrollment in the spring. We will be bringing those back in 2025 for those populations as well. But this is a new offering for our Medicare population.
Okay, so then what you typically do, like for instance, in July and August of 2022, those sessions, there's 19 sessions we had, but what, you don't call them education sessions?
That was specific to the, at the time, the fact that we were changing Medicare benefits and offerings. So that was specific to the Medicare, the then Medicare Advantage plan. But it would be similar in the sense that, you know, we're going to do an overview of the benefit offerings that will most likely be presented by Highmark. We'll have Highmark representatives, CVS representatives on hand to answer specific questions from our state of Delaware Medicare retirees. We'll most likely, but it's not confirmed yet, we'll probably have some folks from the Medicare or from the Department of Insurance as well on hand to assist with just general Medicare related questions. So specifically, we have scheduled the dates, times, and locations for those in-person sessions in each of the counties. Again, we'll be on site, the statewide benefits office, pension office, Highmark, CVS, possibly the Department of Insurance, from 10 a.m. to 3 p.m. on the dates that are shown on the slide, at the various locations in Kent, Sussex, and Newcastle County. And then we'll actually be doing formal presentations 2 different times during that 5-hour span on each of those dates. So this information is all going to be posted on the SBO website, pension office website, and included in the materials that we will be mailing to Medicare benefit eligible retirees in September 30th. Slide. And then, as I indicated, to make sure that we're providing a similar opportunity to those who can't actually be present at those events in person, we're going to offer 2 virtual events as well on October 16th and 22nd. These will be intended to be 30-minute presentations, very similar to the presentations we would do at those in-person sessions. And then we'll have a 30-minute period following those presentations for participant questions. So we're still working through the details on and use of platform and Q&A format for these virtual sessions, but that's the general gist of what we're planning to do in that regard. And again, this will be communicated in those materials to the retirees as part of the open enrollment. Next slide. And then lastly, I just want to kind of wrap up here with a reminder. The committee did approve the special Medic-Fill rates when the active and non-Medicare rates for the July 1 plan year were set back in March. So those rates are published. They are actually posted on the SBO and Office of Pensions website for the 2025 Medic-Fill plan year. The total monthly rate for Medicare retirees enrolling in the special Medic-Fill with the Medicare Part D drug plan, that total rate paid by the state on behalf of retirees and any pension or contribution will be $612.40. For those choosing the special Medic-Fill without the drug coverage, that total rate is $347.20. Now, the state share that we've shown here on the slide is assuming that the retiree has acquired the required years of state service to receive 100% of state share towards those premiums. So as committee members are aware, for pensioners who have 20 or more years of service and retired on or prior to July 1st of 2012, they are not responsible for any portion of that total monthly rate for either plan. And then for pensioners retiring after July 1st of 2012, and again with 20 or more years of service at the time of retirement, they are responsible for 5% of coverage. So those pensioners will pay $30.62 per month for the Medic-Fill with drug, and then $17.36 for Medic-Fill without drug. So again, I just want to call attention to, we recognize there's a small percentage of retirees formerly employed by the state of Delaware, as well as retirees who are eligible for state of Delaware Medicare benefits by virtue of being part of another pension plan that's administered by the Office of Pensions. Those individuals may be required to pay a larger portion of that total monthly rate. There are rate tables posted on the Office of Pensions website to give them more specifics on their situation and what their corresponding monthly rate would be starting January 1st of 2025. Slide, please. And then lastly, with regards to the special Medic-Fill contract, the DHR secretary has authority in Delaware code to negotiate contracts on behalf of the SEBC. So we are currently negotiating that contract. We expect it to be finalized by October 1st. I'm happy to take any questions that committee members may have.
And then as in past years, we'll post that on our website.
Yes,
I see there there's always a chance for redactions.
we
for
would, yeah,
vouchers, so
may have a,
Yeah.
we'll prepare a public version of
That's
the
it, which
contract.
is what we've done this couple of years. Okay. Any questions? No? All right, we will move on and see any questions. I feel like we talk about group universal life insurance every meeting for the past 6 months, but it's important and it's an important benefit. And now we're gonna talk about the RFP.
Thank you, Secretary. Good afternoon, everyone. Jacqueline Iglesias from
Wondering where we're gonna see you,
WTW.
Jacqueline. Like an hour and 15 minutes into the meeting before we saw you.
Good afternoon. Happy to be here. So for today's discussion, we're actually going to talk about two scopes of work related to two upcoming RFPs. The first one being on group universal life insurance. We'll set some brief context for today's discussion before diving into the detail and then opening it up for questions and feedback from the committee. So as Secretary DiMattia has alluded to, we've been talking about this for quite a few meetings now, that the group universal life contract that the state currently holds with Securian will expire on June 30th of 2026. That timing reflects the 1-year contract extension that the SEBC recently decided to move forward with so that more time could be allotted to an RFP. We've had several discussions with subcommittee members about the different life program options that you could consider incorporating into an RFP. And from our meeting last week with the subcommittees, both financial and health policy and planning, we reviewed a proposed scope of services based on prior feedback from the group, as well as gathered feedback from subcommittee members last week, which we've incorporated into today's discussion, which we'll share with the committee shortly. And then we request any feedback or input from the SEBC members about the proposed scope of services, which we'll incorporate into the materials that we'll review today. And following today's meeting, at our next meeting in September, we will request a vote from the SEBC on a finalized scope of services that will ultimately be included in the life RFP that will be released for proposals later on this year. So to provide a brief overview, and then we'll go into some more detail on the subsequent slides, the proposed scope of services for the upcoming life RFP would include 4 life insurance plan options for vendors to quote on. And we've outlined the 4 in this table. So at a high level, option 1 is basically matching the current life insurance benefits offered to employees today. That includes providing employees with a group universal life benefit, or GUL, as you'll see it referenced here. And then spouses and children who are eligible for coverage under the plan would receive a group term life product, exactly like is in place today. Option 2 is essentially building upon the current benefits by incorporating a few select enhancements into the employee and spouse life coverage options. So we'll get into what some of those details look like in a few moments. Option 3 is essentially taking the current life insurance plan provisions that are incorporated into current state, but offering a different life insurance product to employees. So where today we have a group universal life insurance product, in option 3, that would change to a group term life product. And when we get to those options, I'll highlight some of those key differences on what moving from a group universal life to a group term life product means. And then option 4 is essentially building on option 2 by taking the plan design enhancements that we'll talk about in a few minutes, and then layering that on top of a group term life product. So as the committee and proposal review committee and SEBC are comparing and weighing the differences in the merits between group universal life versus group term life for employees, options 3 and 4 kind of give you those more direct comparisons to be able to compare the financial premiums, the financial proposals for bidders between current state offerings and then current state plus those enhancements. One other point that I wanted to make on this slide, and this is in respect to some of the feedback received from subcommittee members at last week's meeting, the SBO will be surveying employees, both those who are currently enrolled in the Group Universal Life Plan, as well as those who are eligible to enroll but are not currently enrolled, so potential plan participants, just to understand better their preferences with respect to these two life insurance products, meaning Group Universal Life versus Group Term Life. That timing of the survey is being targeted for early March of next year, with results available in time for the proposal review committee to consider the voice of the employees alongside of any RFP responses. So getting into more of the details here. So again, option one really just matches the current life insurance benefit. So employee Group Universal Life is kind of the offering in place today. It's an entirely employee pay-all benefit, which is the case for all of the options you'll see itemized here, meaning that there is no state funding made available to contribute to the cost of the benefit. So employees today can elect from 1 to 6 times their base annual salary with a max coverage amount of $350,000. Alongside of the Group Universal Life Insurance policy is a tax-deferred interest-bearing cash value account, and I'll highlight that on the right-hand side of the slide. We've talked about this a little bit in prior meetings, but this is essentially where employees can contribute additional premiums to a cash value account that does have a minimum guaranteed interest rate of 4%. There's also an opportunity under certain circumstances for employees to take loans against any balance in that cash value account. In addition to Group Universal Life for employees, there is also an accidental death and dismemberment benefit that goes along with Group Universal Life. So this additional benefit, or AD&D benefit, basically is the same amount of coverage that the employee elects on Group Universal Life, but this additional AD&D benefit would take effect in the event of a loss of a limb, loss of functioning, or including up to loss of life associated with an accident. And then finally, spouses and children are offered term life insurance options. Both require an employee to elect coverage under the Group Universal Life benefit in order to then subsequently elect coverage for their eligible spouse or child. Again, these are employee pay-all benefits. And for both, employees have the option of electing coverage in the amounts of $10,000 or $20,000 for both spouse and child life. So again, just a recap of some of the main provisions for your current life insurance benefit. So now option 2 is the first alternative design where key differences from current state have been highlighted in red. So one of the enhancements that is included in option 2 is increasing the maximum coverage amount for employee Group Universal Life, going from $350,000 to $500,000 of maximum coverage. This would be applicable to not only the Group Universal Life benefit, but also the AD&D benefit, since we standardly see any AD&D benefits offered mirror the same coverage limits and coverage amounts that are in place on the life insurance side. We also talked with subcommittee members about the potential option for bidders to quote on offering a buy-up AD&D benefit for covered dependents under the plan. We do see from time to time plans offering additional dependent AD&D coverage, which is not in place with the state today. So this would be another potential benefit that bidders would be asked to quote on. And then the other coverage enhancement I'll highlight here in option 2 is around spouse life coverage. So today, coverage options only go up to about $20,000 worth of coverage. And in the greater market, we see a median coverage maximum equating to about $150,000. One subcommittee member suggested maybe capping that limit at $100,000 for spouse term life coverage. So you'll see reflected here now coverage options for spouse term life are ranging between $10,000 and $100,000 in $10,000 increments. So employees now have additional options if they're electing spouse life coverage. In terms of feedback from subcommittee members, there were no objections or concerns noted for any of these enhancements. And I mentioned that there was some interest in including an optional buy-up coverage amount for AD&D for dependents, as well as some interest in including $100,000 as the spouse life maximum coverage amount. Any questions or feedback from committee members so far on options 1 or 2? So moving to option 3. So this is now one of 2 options where the employee life insurance product changes from group universal life to a group term life option. And the key differences from a member perspective, I think one of the biggest differences is highlighted on the right-hand side of the slide here. In a group term life product, there is no cash value account. So employees would no longer have the option to contribute additional premium into a tax-deferred, interest-bearing savings vehicle. Today, under the Group Universal Life Plan, the state has about 13.5% of your current plan participants having ever contributed funding to the cash value account. So that 13.5%, while that may sound a little low, it is actually about twice as many participants as have contributed to cash value accounts in Securian, who is your current life insurance carrier's group universal plans across their book of business. So we are seeing higher levels of participation by state of Delaware life insurance plan participants contributing to this cash value account. And I'll just say in the appendix of this document, we have some additional information on state group or state life plan participant savings into these cash value accounts. So it gives you a little bit better of a sense of, well, how much money is really in these accounts. Offhand, about half of those who have ever contributed to a cash value account do have a balance of over $1,000. So it's a fair amount of participation among your plan participants compared to Securian's book of business. But this is an option moving to employee group term life that had previously been discussed with subcommittee members. There's a much broader pool of potential insurance carriers that quote on group term life insurance products compared to group universal life products. And in earlier discussions, there was some interest in sort of broadening the pool of potential bidders in a life insurance procurement, which is why the proposed options do include group term life insurance for employees. The one other piece that I will note here is that our recommendation would be, in the event of the committee deciding to move towards an employee group term life product, we would recommend that this would be offered as a replacement for the life insurance benefit employees have in place today, and not offered as a choice between group universal life and group term life. This matters because it would be how we would need to articulate that proposed scope of services for any potential bidders. And the reason for this recommendation is really so that offering one in lieu of another would allow the state to have a greater ability to negotiate more favorable pricing terms for employees by offering one or the other, but not both as a choice.
I also think it would be confusing to state employees.
Agreed.
They are 2 very different plans, and I don't know that the average state employee understands that without significant research and understanding.
Mm-hmm. Yeah, it's a great point. So in terms of feedback from subcommittee members on this option 3, so we did hear feedback from several members that had concerns about group term life as an offering being a less valuable benefit than group term life in terms of the coverage provisions, and particularly that cash value account, as well as the fact that if employees were to seek out additional life insurance, purchasing as an individual and not part of a group plan, there is a far more limited availability of group universal life plan options on an individual basis. It's a lot easier to go buy a term life insurance plan as an individual than it is to find a carrier willing to quote individual individual universal life. So that was some concerns that several members raised. One member also articulated some related concerns from other state employees that one subcommittee member heard and articulated in Monday's meeting. It also included some concerns about not having full visibility into what employees value in terms of group universal life versus group term life, which is again what is prompting the SBO to issue a survey in the upcoming months for employees to get some additional feedback on what kind of life benefit they would prefer to have. One additional member expressed some interest in hearing the Delaware Insurance Commissioner's point of view on the merits of group universal life versus group term life, and certainly would invite the representative from the Insurance Commissioner's office from today's meeting to please chime in with additional thoughts here. And then finally, the last piece before I pause is that there was some discussion about having the RFP stating as a requirement that any new life vendor would honor the current vendor's acceptance of proof of good health or evidence of insurability for current plan participants. So even though we discussed this as part of the discussion around this third option, this would apply to basically all 4 options included in the RFP. So if anybody in the current plan has already submitted evidence of insurability or proof of good health, the requirement is that any new vendor would honor that in any future contract. And that's typical in the industry, and we would certainly want to include that in any proposed plan.
Very good. Don't see any hands raised. We will move on to a discussion of the audit services RFP.
Secretary, I'm sorry, if I could, I see Sean just put his hand up and we have one additional option I'll just very quickly go through.
Yes. Sean?
I'll wait until Jacqueline's finished.
Okay. And I believe I also see a hand up from the state treasurer's representative.
Yes, we can wait after Mr.
Okay.
O'Brien.
So in the interest of time, I'll just very briefly go through option 4. Again, option 4 is another term life insurance option for employees. It includes, and you can see from the highlights here, it does include all of the enhancements to the plan design that we discussed previously in option 2, but this is just group term life for employees instead of group universal life for employees. And while this specific option wasn't presented in print, at Monday's subcommittee meeting, we did discuss including a 4th option, which subcommittee members agreed made sense given the enhancements that were being requested on group universal life. It made sense to also look at that for group term life. And that is essentially the content. There was just some additional questions for discussion. So maybe Sean, I'll take your hand up first if you have thoughts or questions.
Yeah, thank you. So can you, for context, I saw I think there's an appendix with some numbers in it, but can you tell us what's the percentage of active employees that currently are participating in the Group Universal Life program?
Sure. So I don't have the exact percentage offhand. The current number of enrollees is just over about 19,000 subscribers, and that would include employees, and I believe that also includes pensioners as well. So there are some pension.
Jacqueline, we had this question when we were doing the extension. Sean, it's about 30%.
30% of actives. Okay. And can you compare that to what I guess comparable employers sort of benchmark that to where you have a, entirely contributory life insurance program, what the participation rates are there? And I understand you may not have that number off the top of your head, but I think it'd be useful context to understand, because part of this gets to, right, there's a bigger question about like, well, what are the objectives of this program, right? And thinking about if you're trying to have something of value to employees, which is, illustrated by the level of participation. I don't know if 30% is a good number or not. Right. So anyway, that'd be interesting to know that and helpful to know that for context. So let me stop and let you address that question.
Yeah, Sean, appreciate the opportunity to take that back and get clarity on that figure. I don't have that offhand, but we can certainly get you that benchmark information.
Okay, great. Thank you. And then for the survey that's going to go out to employees, will the RFP committee members see a draft of that and have an opportunity to at least comment or weigh in?
And that would, I'm not looking for Faith for the timing of that. When do we expect the survey to go out next? January, February?
The survey, we're targeting early March. We wanted that to align with the advertisement of the RFP, so that feedback would be available for the proposal review committee.
Okay, so if there's a proposal review committee prior to that, it would make sense for them to see the wording of the survey. I'm not privy to, do we have the meetings already set for that RFP committee?
Don't know that those meetings have been set, or we've even set the proposal review committees.
So Sean, that would be the only limitation is if that group isn't set up and it hasn't gone out, you know, they haven't had their meeting scheduled yet, but your request is, you know, request for transparency and to understand what the survey would be asking for. So it's a good point for everybody to keep in mind.
Yeah, just I mean, look, I'm not asking for an opportunity for everybody to like group edit it. It's more of, I think it's useful to
Always
get some feedback, right?
Sure. Yes, sure.
Thank you.
Thank you.
Thanks.
Deputy Treasurer Jordan Siemens.
Thank you, Secretary DeMatteis. Jordan Siemens, Deputy State Treasurer. Treasurer Davis sends her regrets that she's not able to join this meeting, but she did want me to attend. And you know, she's been pretty adamant and on the record with her support of the Group Universal Life product that's currently on file with the state of Delaware. She just doesn't necessarily see the value in term life insurance, and she's not convinced otherwise. She does think the state could do a better job of promoting the cash value accounts. It's an excellent economic opportunity, opportunity for state employees to invest some of their money in a tax deferred account to use at a later date. I don't know exactly what those expenses could be used towards other than using it against a loan. But we definitely think the state could do more to advertise and promote the cash value accounts to the enrollees within the Group Universal Life policy. And adding on to what Mr. O'Brien stated about the survey, we agree. We hope that there's an opportunity, the treasurer hope that there's an opportunity for SCPC members to participate in the development of that survey. I suspect that we will have a very vocal response rate from state employees of those that are enrolled with the Group Universal Life Insurance policy. And I think the treasurer would hate to see state employees have to go out potentially to the private market and experience higher rates, higher prices. Yes, Group Universal Life Insurance is a greater cost right now, but it is guaranteed over the course of the policy compared to term life policy. So yeah, she would be in support of, if anything, just RFPing out the Group Universal Life Insurance policy and not going the direction of the term life. Thank you.
I think you just created a verb, Jordan.
RFPing, you try it.
Thanks for the feedback. And we're going to move on to audit services, and we're actually going to defer House Resolution 32 updates to next month. It's not something we have to vote on. It's not something that's going to change between now and September. So we'll move to audit services request, and then we'll go into executive session.
Thank you, Secretary. So similar concept with this topic for discussion. So just by way of a bit of context, so the SCPC's current contract for medical and prescription drug audit services with Brown & Brown of Massachusetts, which was formerly known as Claim Technologies Incorporated, or CTI, will terminate at the end of this fiscal year. So that contract, which was procured from the last audit services RFP, so it's necessary for the state to issue the next audit services RFP. The proposed timing right now that we're looking at for release of the RFP will be in October of this year, with the intent to present an award recommendation from the Proposal Review Committee to the SCBC in April of next year. So since the last audit RFP, there have been some emerging vendor capabilities in the audit space. And we've spent some time talking with the financial and health policy and planning subcommittees about the current audit scope of services, as well as what we're seeing play out in the vendor marketplace about what some of these emerging capabilities look like. So we want to talk about that with this committee today, as well as share feedback from subcommittee members on the proposed scope of services for your review and consideration. And certainly would like feedback and input from committee members as well. The request is that for our meeting next month in September, that the SCBC would be potentially ready to vote on a proposed scope of services for the next audit services RFP. So no vote today, but certainly ideally from a timing standpoint, would like to try to accomplish that at next meeting. So by way of a little bit of background, the current audit services contract includes several key components which are itemized here, such as an electronic review of all medical and PBM claims done by the auditor to ensure that the claim system setup is properly and accurately adjudicating claims as per the plan design. It also includes a more targeted review of a sample of medical claims, as well as targeted reviews of rebates and costs for the top 50 drugs utilized by plan participants. It also includes a review of eligibility to ensure that the dates of eligibility for plan participants, as specified on the eligibility files that the state sends to the carriers, is actually the date which eligibility took effect for those plan participants and not the date that the carrier received the file. So it is also looking at the plan to make sure that the right people are enrolled at the right timing. It also finally includes financial comparisons to ensure that the amounts paid by the state equate to the amounts that were invoiced and paid by the TPAs and the PBM to the to providers. And then finally, both medical and PBM audits include a written report of the findings, as well as some additional hours of support following the audit to assist with resolving open items and open issues that were identified in the course of the audit itself. So when we talk about the scope of services, historically, and including for the state of Delaware, these audit services have focused on retrospectively reviewing the plan experience from a claims and operations perspective. This is very typical in the industry that we see these retrospective reviews take place, as opposed to more real-time review of plan information and claims as they're being processed. This is the case for a variety of reasons, including technology limitations on the audit carriers side that have only until recently been a factor in causing these audits to have been taken place on a retrospective basis. There's also been, I think, historical challenges in getting some of the right data sharing agreements in place to allow for more real-time access. And then finally, claims often take a little while to play out. So claim processing timelines are longer, and there are usually a number of typical claim processing activities that take place, including things like claims that are resubmitted, claims that are reprocessed. We often see coordination of benefit activities where maybe one insurance carrier is responsible for paying claims for a particular individual or particular situation. And then finally, there are from time to time instances where providers are overpaid or a member overpays on a claim, and there's a series of recoveries that can happen, which all play into why audit services are typically done on a retrospective basis. That all being said, and very recently, a few vendors have entered the market claiming to provide a more ongoing and real-time review of administrative claims and fees for both medical and pharmacy benefits. It's a relatively new and emerging area. So as you might imagine, the vendor marketplace for this is very small. We don't see really a lot of overlap in these ongoing claim reviews as we do in the more traditional audit vendor scope of services. From the WTW standpoint, we have very few clients that have actually partnered with these types of emerging audit vendors. And as a result, there's relatively limited data on outcomes and findings from those vendor reviews. I can share anecdotally that we have yet to see play out the degree of savings or ROI that some of these more real-time audit vendors are claiming can be achieved on doing this on a real-time basis as opposed to more retrospectively. So from our perspective, these types of emerging real-time audit reviews would not replace the traditional retrospective audits that the state has previously procured through past audit RFPs. And it is essentially because these real-time claim reviews wouldn't account for what are typical claim processing activities that could very well skew audit results when looked at on a ongoing real-time basis versus retrospectively once a claim has been fully paid, processed, and any adjustments have been made as needed. So we've had some discussions with the subcommittee members about this topic, and from our last meeting last week, several subcommittee members did voice their preference for having the audit RFP, the upcoming audit RFP scope of services focus on these traditional audit capabilities only, for the reasons including that this is still an evolving area of the vendor marketplace. There are few vendors that really do this on a more real-time basis, and as a result, there really haven't been a lot of audit results and outcomes to speak of so far. That being said, the subcommittee did express.
Jacqueline, I don't why we should limit it though in the RFP. I think we should put an RFP out there that asks for both and see what we get back. I don't think we need to knock ourselves out of the game before we even, the first pitch is thrown. I think that we limit ourselves to, these, your word, traditional audits that in the era of AI and advances in I don't even think it's real time. I think that's a bit of a misnomer name of really making sure that the state isn't overpaying on a whole range of services, not just traditional hospital claims. So I for one would prefer that we talk about including both in an RFP. I don't think we need to pick one over the other. I don't think that's the purpose of an RFP. That's my opinion. Any others? Points you want to make? Jacqueline, I'm just conscious of the time.
No, Secretary, and thank you for those comments. We've certainly noted them. I think the one other point that I wanted to raise, just in terms of continuing to stay in touch with the marketplace, and it could very well be a moot point based on your feedback just a moment ago, but one of the items that, as we were debriefing with the SBO following the subcommittee meeting last week, we didn't talk with the subcommittee about potentially shortening the term of the next audit contract. Usually it's a 3-year term with 2 one-year optional renewal periods, but in this case, a shortened contract could look like a 2-year term with 3 optional 1-year renewal periods. And the point would be, if the committee wanted to give itself some additional flexibility to go out to RFP after this next one, go out to a subsequent RFP sooner rather than later, again, allowing for the vendor marketplace to mature a little bit, even if the next RFP does include questions about those emerging vendor capabilities. If the committee decides ultimately to not go down that path for next year, looking at a slightly shorter contract term awarded in this next RFP could still provide the committee with some additional flexibility, 2 to 3 years from now. So that was the only other piece I just wanted to raise for today's discussion.
Okay, and Tom, you had your hand up. Tom, we can't hear you. Hang on, give us a second on our end. Tom, you want to try again? It's a little icon on the upper left.
This is the cell phone. He is unmuted.
Tom, you're unmuted. Do you want to try again? Give us a second here. No? I think we lost you, Tom. Tom, feel free to send either in the chat or feel free to send us the group an email and we'll follow up on your comments. Sorry about the technical difficulties. Okay, anything further on this? Okay. Then I will entertain a motion to move into executive session.
So moved.
Sean, second.
Bethany, I'll
Second.
second.
Thank you very much. All in favor?
Aye.
Thank you, everybody. We'll
Aye.
come back to public session after a relatively brief executive session. Thank you. back in executive session. Excuse me, we're back in public session. Waiting for quorum to join. You let me know when.
Need one or two more. Have 5 currently, so we just need one more. You do have a quorum, right?
We are back in public session. Is there any other new business? All right, not, our next meeting is September 23rd. Monday, September 23rd. We'll see everybody then. May I please have a motion to adjourn?
Motion to adjourn. This is Josette.
Second, Bethany. Thank you very much. All in favor, signify by saying aye.
Aye.
Great.
Aye.
Everybody, take care. Have a great Labor Day.